Good afternoon. I am Dr. Jyotsna Mirle, welcoming you from Life Clinic, Bangalore, India. Today we are having a kind of an interesting discussion happening in our clinic, and it's titled as The Cup That Cheers. This is actually the beginning of a series that I would love to hold a kind of coffee afternoons on Saturdays whenever I can. And the objective of this is really to help people who are seeking treatment for fertility issues to understand what is actually happening to them and how is it that they could face the situation better, and how is it that they could probably look at achieving success with a lot less anguish. In many ways, I would like to say that in terms of technical finesse, medications, and methods of investigating couples, we've almost reached to a point where there is nothing much more that we can do. But where I feel that there is a huge gap that needs to be bridged is the fact that couples need to understand how they need to view what is happening to them. And by just looking at the same thing that they're going through with a slightly different viewpoint, they would probably be able to ease into the situation better, to get rid of all the stresses and tensions that would exist otherwise, and would probably be able to stay with the treatment for longer intervals of time, which is probably the key to success. A large part of what we are going to do this afternoon will be also uploaded on my website, and you could go through it. I also plan to have a synopsis of what I'm going to say today in a text format, which will probably be up on my blog soon. So I hope you enjoy what you're going to watch and read, and I hope this helps. Thank you. Welcome again, and thank you for being here. My talk today is titled The Cup That Cheers, again for no good reason other than it just sounded nice. And we'll start with, I just needed a title to work with, so we're starting with repeated failures in IUI and IVF. So we'll start with the first slide. So when you look at definition, you can come in. So when one looks at definitions and sees what is fertility or what is infertility and so on, this is a very, what shall I say, something very general that you might find in a book which says that a person is fertile when they can conceive and have a child. And always when you look at how can you prove fertility, you can prove it only as something that has happened, or you can predict it. So it's either something like what we call in medical terms prognostic. That means we can say about it, or we can say it happened. But right now, as we're sitting in front of each other, we cannot put a score or a mark or some kind of a signal to say that this couple is fertile. I can only say I can predict it. Okay, so most of the things that are defined in our books are more of a predictive kind of value. Next step. By converse, infertility traditionally is supposed to be a couple who doesn't get pregnant after 12 to 14 months of unprotected intercourse. And why is it that people have stopped at 12 to 14 months? I think because studies have shown that if a fairly normal couple keeps trying with regular intercourse, at the end of 12 months, about 87 to 90% of them are pregnant. So which means that keeping your time gap of about 12 months, most of the couples should have got pregnant. If you increase the time at say 24 months, then you will have more number, but the jump from 87 or 90 to the next mark is a very small one. Maybe 93% will be pregnant at the end of 24 months. So instead of prolonging it, we just have a definition which says at the end of 12 months. But the new thing that we need to remember here is that when couples are older, it's better to think that you will need help a little earlier, so that issues that might come up otherwise will be catered to earlier rather than later. So if you look at causes, again I feel this is important with view that there is a lot of self-blaming, or there is a blaming which is sometimes very obvious or sometimes very subtle about how you want to distribute the distribute the blame. So is it my fault? Is it his fault? Is it our fault? Is it someone else's fault? Am I stressed? What is happening? Or did the doctor who take care of me all these years did not do a good job? So where are we? So actually speaking, it's difficult to say Well, if you look at percentage wise, here it is. And the balance, what I haven't written there, would be a mix of a male and female factor or something like that. But as a rule of thumb, I do not like to actually highlight it as something that is his fault or her fault or something like that. As far as possible, I would like to look at it as something that needs to be made better so that we can ultimately achieve a pregnancy. But this is how it is classified in the book. Next slide. So I'm going to spend some time with this slide, and the next couple of slides will be about the topic of unexplained infertility, because we find that a lot of couples do belong to this group. So why is it important to talk about unexplained, other than us having more patience with unexplained infertility? It's also true that this is probably the best group of couples who ultimately would achieve pregnancies. They are people who do not have real reasons for not conceiving, like no sperms, and like I mentioned, no tubes and such other things. So these kind of couples do end up with good care, having a good chance to become pregnant. And just the basics of IUI, it's done in mild subfertility for men and women. It cannot be done in major infertility reasons for either man or woman. You need at least, let's say, 15 million, 10 million sperms, motile sperms, to be there in the sample for the IUI to be successful. If it's much less than that, then it doesn't make sense to stay with IUI. It's much better to move towards in vitro. It's effective in this group of people provided you've chosen well. It's safe because we do it with minimal stimulation, so the side effects of the drugs and everything is much lesser. It's also, I think, quite economical, because the chance for you to get pregnant, although limited per cycle, at the end of 3 to 4 cycles, there is a fair chance that you're pregnant. The important thing is for whom. So that is where our success lies. If your doctor chooses the couple wisely, then the chances of that couple getting pregnant with that particular treatment is very high. If you choose wrongly and try to fit the wrong couple to the wrong treatment, it's going to be an endless road. Next slide. Basics of in vitro, again, I haven't gone through details in this talk, but basically in vitro cycles are meant for couples who probably either require it because the number of sperms in the man are too less, or the woman is having some kind of an ovulation problem that is not getting sorted out by simpler methods, or they may have tried simpler methods and not got pregnant. Basically, it's a kind of a technologically very intense method where you require an excellent lab, you stimulate the woman's ovaries, remove her eggs, inject the eggs with the sperm, and then re-implant the embryo cell inside the uterus. The effectivity of this is much higher than an IUI, but what prevents us from making everyone go through an IVF cycle is the cost. In India, the cost is high, and it's not being subsidized by the insurance companies. So when you look at what is it that makes IUI or IVF successful, the most important take-home thing from this presentation I would like you to understand is ignore everything else in your results, in your reports, AMH and so many other things now that women worry a lot about. We are not there in terms of completely predicting things with all these newer reports. What we know for sure is that age is the one factor that is contributing directly. So the older the woman, the lesser the chances for a successful pregnancy. The younger the woman, it's a big positive factor. Also period of infertility. Couples married for more than 5 years, 6 years, trying to do a very simple procedure on them, like take oral tablets and have intercourse from such a day to such, may not work. At that point in time, the doctor needs to be more proactive, because the longer the duration of infertility, it usually means that probably a little more aggressive kind of treatment is needed. What kind it is up to the couple and the doctor to decide, but it is an important thing in making a decision, the period of infertility. Previous pregnancies, repeated pregnancy losses, for example, women who get pregnant and miscarry, who get pregnant and have a stillbirth, whatever it is. So the risk factors there are much higher. This again allows us to make decisions more guardedly about the whole thing. A previous successful pregnancy, by the way, is a good positive thing for a couple couple to try for the second time. Whether if it is like IUI isn't working, I think that the switch to IVF can be done with more confidence in this couple versus someone who hasn't had a child at all. So couples married for 10 years, had a child who's 7, 8 years old, and then suddenly they are back, without having a baby. Maybe that couple are actually more confident to an IVF rather than someone just married for 9 years and not having a child. Other factors in the women, diabetes, hypertension, obesity, all these things will pull down your results. Same factors in the man, systemic illnesses in the man, bad lifestyle, smoking. And the technique and procedure itself. So choosing your technique correctly, what you're going through, is it IUI, is it IVF, where are you going to do it? Is this lab capable of handling what we are looking at? There are many labs in the city and all of them are pretty good, but each one has something that is going to offer uniquely to you. So it's good to choose a lab with care so that you know that you're going to get the best out of what you're going to give them. Next slide. So, in spite of doing everything according to whatever we have, we've chosen the patient with care, we've chosen the drug with care, we've chosen literally everything with care, but yet we find that it doesn't happen. That means success rates in IVF and IUI are still pretty fixed. You cannot increase success rates no matter what you do beyond the point in a good group of patients. When I say a good group of patients, someone you have chosen wisely for that particular procedure or someone who you feel is a good fit for that procedure. We do everything we can and still we can get a negative test at the end of it. And why is this so? Because this is how it works in nature. So the way the human body is made, I have said this to patients who come to me, so maybe it's a repetition for some of you, but the way our bodies are made, I think in terms of the reproductive tract, we are not very efficient. We are very good with our heart and the blood vessels, our nerves, our muscles, and everything are very, very good. But if you look at the reproductive tract, you find that it's a kind of a wasteful method that 50 million, 60 million sperms to be released for one oocyte, and if that particular event happens mistimed by 18 hours, the egg is dead, and then you have to go through another full month cycle. So if you look at the way it happens in nature, it's not very efficient. And even in nature, the most fertile couple who's trying for the first 12 months just has maybe per cycle, per month, if you look at, not more than 30 to 40% chance of being pregnant in that month. Maybe at the end of the year, let's say there's about 80 or 90% of them pregnant, but that month we are talking of it's only 30 to 40. So it is true that the way the human body is made is it's kind of a wasteful way in which it's programmed where reproduction is concerned. And all embryos that humans produce, whether naturally or in a laboratory, they are not normal. So they look normal even in the most technologically advanced microscopes, but when you genetically test them for whatever reason that you genetically test, you'll find that a large number of them are abnormal. Abnormal embryos will behave exactly like normal in a lab setting, and the difference happens only when they need to go to the next stage of organ formation, when they stop forming, they stop at that point, and that is looked upon as a negative pregnancy test or an early miscarriage sometimes. Next one. So when we look at can we enhance results, I mean this is something that is oftentimes asked as to how can we make things better for ourselves, how is it that we can improve results in whatever we have chosen, whether it is IUI or IVF or whatever it is. So here is a list of things that can be done, maybe is being done, but we can get better at doing it. And when I say we, I am speaking for the doctor. So what is the one thing that should work for couples better is if your doctor is good in counseling and explaining why that we are planning to do a particular procedure for you. And we do need to look at individual protocols. We cannot say that everybody who comes will get this dose of medicine and this scan on that day and that. It doesn't work like that anymore. So we are in the era of individualized protocols. The era of generalization is clearly over. So we need to have tailor-made protocols so that there is no risk and efficiency is better. Safer medications, yes, for sure. I think there are lots of medications now which are available in all kinds of companies. So choosing your medications with care, making sure your doctor understands that there are safe and unsafe medications, dosing it correctly, all these will also go a long way in making sure that you will have a safer cycle. What kind of technology that we can depend on to rescue us from, lower pregnancy rates? Among the things that are new now is the instrument called an embryoscope. Embryoscope is something that allows the embryologist in an IVF department to choose your embryos without needing to remove it from an incubator. So an embryo needs to grow in a very particular type of environment, and if this embryo grows you keep removing it out and you expose it to the atmospheric oxygen, it doesn't grow. So if you still want to keep on looking at it, you need some instrument which will keep on giving you pictures of that embryo which you can look at in your computer screen, and that is what the embryoscope is about. The chances of pregnancy success may be increased by about 8 to 10% when we choose an embryoscope versus without. And PGD and PGS is genetic testing of the embryos. So it's pre-embryonic genetic diagnosis and pre-embryonic genetic testing. So in PGD, we kind of know where is the fault in that particular embryo. Family linked disorders, we know that this particular chromosome in this particular segment has to be faulty. So you can make a probe to just test that much, and that is PGD. It's done for people who have thalassemia, for example, or muscular dystrophies and things like that. So you know that embryo should not be inserted. PGS is when you're looking at the genome of the entire embryo, where you're suspecting that maybe the numbers of the chromosomes are, not as they need to be. Sometimes we have close cousins marrying or a relative marrying, so then they would probably benefit with the PGS. These will help us to put in the healthy embryos versus the ones which are not. In vitro maturation or IVM is a new technology where for women who have the tendency to overproduce eggs, we will be removing the eggs from their ovaries with minimal stimulation so that they don't have very large ovaries and high estrogen, and we mature these eggs outside in the laboratory, and the risk to the mother is very less and the pregnancy rates are very, very high. So IVM is another good forward step to improve success rates in groups of patients where the risk of overproduction or hyperstimulation is very high. ERA is also endometrial receptive array, and this is something where sometimes we have women who just don't implant an embryo. We put the best embryo, it doesn't get implanted. Now this test will allow us to scrape the lining in a cycle previous to the implantation cycle and check to see whether there is something called an implantation window which can close early or it can close late. So we can find out when is it that is the best time to put it, and this is done actually through testing the genetic makeup of that particular endometrium. It's not done in India where we send the sample to Spain. Right now it's costing us a lot of money, so we are disadvantaged by the cost right now. So we have done very few ERAs, so we yet don't know whether it's really of use to improve pregnancy chances, but it is there. Embryo freezing. Again in IVF we find that when there are too many embryos that are formed and we try and implant them in the same cycle, the woman doesn't get pregnant because she's having too much of a high estrogen and it's not going to go well with conception that month. So now we have the idea that freezing all embryos, leaving the woman alone, bringing her back next month and doing it in the natural cycle, implanting the natural cycle, this is again increasing pregnancy chances by quite a lot. So we've spoken about, we've defined what is fertility and infertility and what goes into making someone have unexplained infertility, and we spoke about how can we make it better and all of that. So, but having said that, maybe there is still this feeling that, okay, we've heard all of this, but what else? Is there anything else that is going to make the load lighter? Okay. So, I just said yes. So let's see what that is. Next slide. So this is what I want all of you to understand very clearly. Getting pregnant is something that ultimately everybody will. I know that when I say that, a lot of people are looking at me with a lot of skeptical faces and like, no, happen, but it's not true. Pregnancy and conception will happen. It is an act of nature, and I rested at that because there's nothing that any doctor or a human being can do to achieve a conception. We can only create a situation which maximizes your chance of conception, but that is it. And we do it repeatedly and leave you there because there's nothing more anybody can do. So, in that realm of safety that is there for you to conceive, these are the things that we do, like I mentioned, an IUI, IVF, surgery, whatever. So, what is important now is that the couple perceives that this is something that we need to do maybe a couple of times for a while or whatever it is. So, getting information is important. Getting a treatment plan which you can stay with, because if you keep changing a treatment plan too quickly, it makes no sense. Yeah, you may get pregnant quicker, but I'm not sure whether it's necessary. Understanding the nature, what is it that's really going wrong within your body, and why is it that you're needing that many more tries than someone else? Set realistic goals. Trying to get pregnant the first time you do an IVF or an IUI may not be realistic at all. So set goals that are important and try and see if you can manage whatever stress that this entire treatment brings you. I think stress is largely brought about by having this feeling of disappointment that happens to all of us. We expect something and something else happens, and that gap in between what we want and what happens is what I think ultimately causes the stress, and that builds when you do many attempts of whatever treatment you're taking. But end of the day, you have to understand that it is about taking those many attempts and that you will get there, and that is the plan, which is not something I have written or someone else has written, that is the plan nature has written. So we have to stay with the plan that is already existing. We cannot change too many things. The day we change too many things is also the day that we will have abnormal children. So staying with the plan is something that is going to be very necessary from the end of the patient. So how do you stay on the plan? Be more open with your doctor or your caregiver, converse, understand things, take breaks if you feel that it's getting too much, whatever it is, but staying with the plan is what is most important. So this is all that I have to say about what I have in my slides right now. But if there are questions that any of you need to ask me specifically about yourselves or about anything else that you've heard today or whatever, feel free to ask me right now. Any other questions? So, here's a question. Will genetic analysis of an embryo be done during an IVF? What is the method? Yes, we do genetic analysis of an embryo, and this is called a pre-implantation genetic testing. What we do is we grow the embryo for 3 days, and we can either remove one cell of the embryo called the blastomere, and we can test that embryo cell, the genetic material of that embryo cell in 2 ways, PGD and PGS, like I said. PGD is where you know which chromosome is having a mistake, and you know that, okay, that particular, see, just for example, I'll say that there is a condition called muscular dystrophy, okay? Now, muscular dystrophy is usually, the woman carries the gene, but the boy suffers it, okay? It's called an X-linked disorder. So when you test an embryo for muscular dystrophy, because the wife says that my brother has it, my cousin brother has it, I don't want my son to have it, so you can know exactly which gene, which chromosome in her embryo to test. And if it comes out as a boy, you are not going to put that embryo, you will put only the female embryos, because that embryo which has the female genetic thing will not have dystrophy. So yes, we can do genetic testing on embryos. It's done on the day 3 embryo, and we normally freeze embryos that cycle, and we put the embryos back next month, because by the time we get the report, maybe the woman's endometrium is no longer receptive. Or now in some labs we're getting it in 24 hours, so we can do a day 5 transfer of embryos. So I think as of now, biopsy is done for day 3 embryos and implantation is done as day 5 embryos. What is the method? I just spoke about the method. And how do you slice, how do you remove one cell of the embryo? I think you need something like a laser probe to do it, and of course a lot of expertise, because you have to shave off one cell of the embryo and study it and then see if the baby is okay, that particular embryo is okay. Is it being used generically? Can we now suddenly say, okay, we have technology now, can we start testing everybody's embryos and then put only the healthy ones? You might, but animal experiments have shown that it's not increasing pregnancy rates by any great length. So you would be overdoing a lot of things to a lot of people without any reason to do it. So right now in humans we are still offering it only to couples where there is a real reason. We're not doing it across board because of what we learned in animals. Things to do in the two-week wait after embryo transfer in IVF. How to be mentally stable. Yeah. So this is something that we really feel very concerned about for all couples who go through IVF, because that 2-week period after implantation is, I think, the toughest time that patients go through, waiting for the results to come. I don't have an answer which will probably answer everybody's question in mind, but broad-based, I think it's good for the woman to be a little busy. I don't think the concept of lying in bed for 14 days is going to work anyone any good. So probably getting back to a routine and trying to keep doing what one needs to do to keep life going, I think is an important factor which will probably reduce the tension and stress in people's minds. Maybe a better answer would be from a person who's been through it. So if there are people here who've been through IVFs and done something that has helped, then you can share maybe at the end of the talk. But I've always been on the other side, so I've always found it easy to talk about it, but going through it is something that is a personal thing. So I would say keeping busy, keeping occupied, and having probably access to your doctor or her team is something that will work well, where it could be small questions that you need to ask and it needs to be answered and keep you comfortable. So those things maybe is with supportive spouse, of course. ERA, question mark. Is there any faulty chromosomes? This procedure is going to rectify this. Okay. Actually, ERA is something that you don't do so much for the embryo, you do it for the endometrium. So, if the endometrial genetic signal that comes out, so when we send the endometrial sample, the uterus lining sample for receptive assay testing, we don't test it like how you would test after a DNC. Okay? We will test it by looking at the signals that it will give in terms of the genes. Okay? So there is a particular curve that is supposed to come when you test these genes. If the curve is looking different, it means that this particular endometrium is either pre-receptive. That means you have taken the sample before it was open for implantation, or it becomes post-receptive. So let us imagine there are 3 patterns that are typically seen: pattern A, pattern B, pattern C. Pattern B, let us say that is the ideal pattern. Pattern A means too early you have put the embryo. Pattern C means too late you have put the embryo. So there are only 3 options available in the ERA. So typically I believe if you get either a pre or a post-receptive status, you are supposed to redo it till you get the receptive status. So that's going to cost a lot of money. So what here I think we are doing is that if you get a pre-receptive, we wait for 48 hours and then put the embryo in the next cycle. So ERA is not so much for the baby, it's for the endometrium. So thank you again for coming. I appreciate it's a Saturday evening. I'm sure everyone has better things to do than listen to the same thing, but it's nice. It's nice to see all of you have made time to come. Really appreciate it. Thank you.
We should actually thank you for so much of information.
No, I'm glad. I'm just happy, and I hope it helped. That's my main thing. That's because there's nothing new I've said. It's just that I need everyone to look at things differently, because there is no other newness in this. The newness has to come from the person who sees it. That is what has to be different. Because that is what will help everyone to stay calmer, stay with what you need to do and get there. Because the fact is that everybody will get there. But right now everybody is getting there in such a rough and tough way that I'm not sure that's the right thing. So I just want to make it a little nicer.